evening, everyone, and welcome to our first ever virtual Doc Talks at St. Joseph's. My name is Michelle Campbell, and I'm President and CEO of St. Joseph's Healthcare Foundation. Thank you so much for joining us this evening for what will be an informative and important presentation about something that matters to all of us, our eyesight, specifically retinal disease. There are almost 400 people joining us tonight for our virtual Doc Talks. And that's not just people here in London, that's people from across our region, and we understand some people from outside our province as well. So welcome to all of you. Tonight's lecture is part of our DocTalks series featuring leading physicians and researchers at St. Joseph's Healthcare London. These health discussions were created just over a year ago to give our community some insight into how experts at St. Joseph's are tackling the pressing healthcare issues of our time, issues that matter to you and to your family. Before we begin, I would like to thank our corporate partners, CIBC, and the Seabrook Financial Group at CIBC Wood Gundy for making tonight's presentation possible. We're incredibly grateful to CIBC for supporting the DocTalks lecture series through their sponsorship virtually since the beginning of our DocTalks series. Please note that tonight's presentation will be recorded. While everyone's microphone is muted and cameras are off, you can see us, but we can't see you. Anything you post in the chat or the Q&A will be included in the video that we publish in our YouTube channel afterwards. We do this in case you missed parts of the presentation and would like to see it again, or you would like to share it with family and friends. And in fact, you can see all of our earlier DocTalks presentation by visiting our website. We encourage you to ask any questions you have for tonight's presenter using the Q&A forum, and instructions on how to post your questions are posted in the chat. We'll set aside a bit of time at the end of the presentation to take some of your questions and to answer as many of them as we can in the time we have, although I understand there's a big hockey game on tonight, so we're not sure how many people are going to stay for a very long Q&A afterwards, but we'll get to as many of your questions as we can in the time we have. Ordinarily, we would be gathered together in the Shuttleworth Auditorium at St. Joseph's Hospital. And as I said, we're missing seeing you tonight, even though you can see us. And that opportunity would be full every time we would present DocTalks. And on each of those occasions, there was a man who always sat in the front row who never missed DocTalks, and that was Mr. Bruce Zubik. He enjoyed this series very much, felt it was an important contributor to community information and knowledge coming out of St. Joseph's in our community. Sadly, we lost Bruce to cancer earlier this year, and I want to take this opportunity to dedicate tonight's DocTalk presentation to his memory. We sure miss you, Bruce. Tonight's lecture is about something especially important to all of us, our eyesight. There are more than 1.2 million Canadians who struggle with some form of vision loss. And as we get older, the chances of experiencing age-related or chronic disease-related eye problems increases, especially issues affecting the retina. St. Joseph's is home to the Ivey Eye Institute, a leader in state-of-the-art medical and surgical eye care for people of all ages. Our program at St. Joseph's serves a region of 1.6 million people across southwestern Ontario and manages more than 140,000 patient visits each year. Tonight's presenter, who is a great friend of our foundation and a great member of the Ivey team, is an expert on two common retina diseases that contribute to vision loss: age-related macular degeneration and diabetic retinopathy. Dr. Tom Sheidow is an ophthalmologist and surgeon at St. Joseph's Ivey Eye Institute, an associate professor of the Department of Ophthalmology at Western University's Schulich School of Medicine and Dentistry. His major clinical and research interests are in age-related macular degeneration, and he has also been a participant in many of the major AMD and diabetic clinical trials over recent years. Dr. Sheidow is a fellow of the Royal College of Physicians and Surgeons of Canada and a member of the Canadian Ophthalmology Society. Currently, he is the retina section editor for the Canadian Journal of Ophthalmology. He is a distinguished professional, a great friend of St. Joseph's, and we're so proud of the work that he and his colleagues at Ivey do for all of us in the region to look after our vision. Ladies and gentlemen, it is my distinct pleasure to welcome to DocTalks Dr. Tom Sheidow. Tom, the floor is yours.
Thank you, Michelle, for the invitation to speak this evening. And I also want to welcome everyone to tonight's talk on understanding retinal diseases. I really do hope that I can make this both an interesting and informative talk for everyone out there and overview a little bit of the changes that we're seeing over the last few years. I should mention that when Michelle first asked me to do this talk, I was a little bit taken back on how I was going to combine macular degeneration with diabetic retinopathy. To me, the two topics are very different. But then I got thinking about it over time and realizing that really they have very many similarities in the impact they have on our patients, on the way we monitor and treat. And so realistically, I'm very interested in trying to pull something together that shows how we monitor and take these two diseases forward. I just have to somehow get my share screen up and we'll be all set to go forward. I apologize for slowing everything down, everybody. If I can, I just want to make sure that we're all on the same page as far as what I'm talking about. And so if some of you will allow me to digress a little bit, I like to think of the eye as an old-fashioned camera. You've got the light entering through the lens at the front being focused on the film at the back. And for those of us not old enough to know what film is, you probably don't need to know about age-related macular degeneration either. But in the eye, the retina is like the film in the camera. It's the part of the eye that actually sees. It's the rods and the cones that are actually involved with the seeing process and transmitting information through the optic nerve to the brain. And when we talk about a retinopathy, we're talking about any disease that affects the retina. And so there's many different forms of retinopathy, macular degeneration and diabetes being two of them. And some of the terms you're going to see, AMD, DR, are just short terms for age-related macular degeneration and diabetic retinopathy because sometimes I can't fit them all onto the screen. When we talk about the macula, we're talking about the central portion of the retina, and that's the portion that is responsible for all reading and detailed vision. And the word edema refers to the term I like to call swelling. Swelling of the macula is diabetic macular edema, and it affects your central reading vision. And lastly, a short form that you're going to see me mention a lot when we get to therapeutics is VEGF, the vascular endothelial growth factor, which has really become one of the most important things in our current armamentarium of treatments. So when we're talking about the retina at the back, everyone's heard of the rods and the cones, and these are the photoreceptors. But a lot of times we don't give enough credence to the two layers underneath that, the RPE or the pigment layer, which acts as a barrier between the photoreceptors and the choroid or blood layer. And it's very important in the removal of waste because when light comes into our eyes, our retinas absorb that light, turn it into sight information, but all the waste material needs to be disposed of, and the amount of light our eyes take in on a daily basis makes that a very active part of our eyes. And the choroid or blood layer is actually the most dense blood layer in your body. And so it's normal that just like any other part of our bodies, our eyes age, but normal aging includes the retinal arteries becoming somewhat more narrow. It includes that gradual separation of the vitreous or jelly from the retina that many of us experience a few floaters. But macular degeneration is just different. It's a disease of older people. And it differs from normal aging because it actually results in a loss of vision. And it's important for everyone in the audience to realize that it is not normal for people to lose vision as they get older. That is not part of our disease. I'm not sure if you could see my screen. What happens with macular degeneration, and Krista, please let me know if there's any problem seeing the screen, is that those waste materials that I was talking about earlier, as they accumulate in the retina, the RPE cells are not able to get rid of them. And so what you'll see is a collection of material under those cells. And we can visualize them when we look into your eye through your pupil. And we can see many little white dots that represent this material, and we call them drusen. And I think the simplest way to think of drusen is they are collections of waste material that make the distance between the seeing cells and the blood layer that serves them with nutrients further along. We talk about two forms of macular degeneration, a dry form, which affects about 85% of patients. There's a slow loss of those rods and cones, but it only causes about 10 to 20% of the vision loss associated with this disease. Whereas the wet form of macular degeneration affects only 10 to 15% of people, but it results in a rapid and sharp decline in central vision, typically over the span of a few weeks or a month, and it results in 80 or 90% of the vision loss from people with macular degeneration. Diabetes to me is vastly different in the sense that eyes are only one part of the disease. Where macular degeneration affects only the eyes, diabetes obviously is an effect on the entire body. And we tend to break these effects down into two forms, the microvascular or small blood vessel forms, and the macrovascular or large blood vessel forms. And it's important, at least from this portion of the talk, to understand that retinopathy is the major microvascular complication of diabetes. How that happens is that the elevated blood sugar levels result in some damage to the finest blood vessels at the back of the eye in the retina, called the capillaries. That damage results in changes that result in the production of that growth factor I mentioned earlier, VEGF. VEGF attempts to help the situation by encouraging the growth of new blood vessels and trying to restore the oxygen supply to the retina. But what in fact it does is it results in what we call ischemia, or a loss of oxygen supply to the retina. And this in turn results in two major problems for diabetics. Some of the blood vessels become increasingly leaky or permeable, resulting in the edema I mentioned earlier. And other things is the development of new blood vessels, which sounds like a good thing, but it is not. Those new blood vessels proliferate or grow in a way that does not help your vision. And so just like with macular degeneration, we really have two forms of diabetic eye disease. We have a non-proliferative form, or NPDR, and a proliferative form in which the abnormal blood vessels are growing. And for those of you who are aware, diabetic macular edema, or swelling of the retina, can occur in both forms. It's not an advanced portion, nor can it cannot happen in the advanced forms. And so it's important to look for this in both cases. Diabetic changes are clearly visible when we take the time to look properly at the back of the eye. This doesn't require any special tests. You can see at the back of the eye some very fine little dot red spots that are the microaneurysms or dilation of the small capillaries. You can see some yellow spots that represent cholesterol or exudate, which has leaked out of the blood vessels. And you can also see some larger hemorrhages. As the diabetes worsens in the retina, the blood vessels start to look more angry, as I sometimes explain to patients. Or you can get these white spots that are called cotton wool spots that indicate that the nerve transmission to the brain is being affected by the ischemia that I mentioned earlier. And lastly, at the most end stages, we start to see the growth of blood vessels like rats' nests on the surface of the retina. And what's interesting and important to let patients know is that at this point, a patient can have excellent vision with little or no noticeable symptoms, but that can change literally overnight by the development of a vitreous hemorrhage or a traction retinal detachment, so that what you end up with is almost no sight out of the eye. Macular edema, again, is a visible thing where you can see the area of swelling with the exudates or cholesterol present and the thickening of the retina. And again, it's due to a breakdown of the barrier layer related to VEGF. And again, in the initial or early stages, you may not notice anything, but as you can see, as it progresses, your ability to make out and discern more detailed items goes away. The two diseases are similar in the ability for us to model them with a couple of different tests we have. One being something called an intravenous fluorescein angiogram. Essentially, we inject a food-soluble dye into the hand, and then we snap photographs. On slide left, you can see a blood vessel growing like a little nest right under the central vision in someone who has wet macular degeneration. And because that blood vessel is abnormal, it doesn't hold its water as well as it should, and you develop this leakage and swelling. Similarly, in diabetes, just in a different spot, the blood vessels grow, but they grow abnormally on the surface. So instead of under the retina, they're on the surface of the retina. And what they come from is these bigger areas of loss of circulation. And so you can see in this black patch, there are none of the finest blood vessels supplying nutrients to the retina. A more common test that many people may have seen or had is called an optical coherence tomography, or OCT for short. This test allows us to visualize the finest retinal structures. It shows traction, but can also reveal the earliest amounts of edema or swelling that you could see from this little heightened area here. So why do we care about these diseases? Well, certainly it's because of the impact on our patients, on our family, and on our friends. To start with macular degeneration, I would call it nothing short of an epidemic in the sense that 30% of patients over the age of 75 suffer from this disease. And it is clearly the leading cause of visual loss in Canadians. And in fact, if you take prostate cancer, breast cancer, Alzheimer's disease, and Parkinson's and combine them all, 4 diseases you've all heard of, less patients have those 4 things put together than macular degeneration. Its impact is staggering in that the World Health Organization has caused it the leading cause of blindness in developed countries. And in fact, the CNIB currently reports that more than 50% of people who apply to seek assistance from the CNIB are applying because of macular degeneration. And in fact, it has been stated that we will lose more sight from AMD in the future, if only because our population is continuing to age. And it's not just the loss of sight that we have to worry about, it's the secondary effects. People with macular degeneration have been shown in studies to have a twice increased fall rate, a quadrupled increase in the need for assistance in daily activities. They suffer from anxiety 30% more of the time, and depression 42% more of the time. Diabetes is no shirker. It doesn't fall far behind macular degeneration. In North America, 37 million people have diabetes, and that number is projected to increase by 37% by 2035. Although we like to think that we are further ahead than our neighbors to the south, Canada clearly ranks 3rd in the prevalence or number of patients between the age of 20 and 80 who have diabetes. And this is really due to a number of different factors. One is our population is aging, and our ability to control the other factors of diabetes has improved, and so our diabetic patients can live longer, which is a great accomplishment, but it increases the number of patients with diabetic eye disease. There's an increasing percentage of obesity in our population, and that is linked with diabetes. There's a growth in immigration from high-risk populations, and we are certainly, unfortunately, seeing more obesity and diabetes in childhood. It's also important to put a little bit of a criticism towards we as medical professionals. Although diabetic retinopathy is the leading cause of severe vision loss in patients of working age population, and it's the most common microvascular complication of diabetes, physicians commonly are focused on the heart and the macrovascular changes, whereas the number one concern for patients is the fear of going blind from diabetes. And we need to turn that misconception around. Many people will ask, well, how many people with diabetes actually develop eye disease? And although this is an old study, it really clearly points to what happens. Back when this study was done, they looked at the patients turning diabetic before the age of 30, and then they found that within 15 years of turning diabetic, 100% of patients, if you looked at the back of their eye, could have some form of diabetic retinopathy, and almost 1 in 4 had the severe or proliferative form. In the older age onset, that number wasn't quite as high, but still was upwards of 80%. And interestingly, many of them had diabetes at the time of diagnosis, suggesting what we all know, and that's that diabetes is present in some of our older onset patients long before it's actually diagnosed. But it did raise the question, once I have diabetes, does controlling my sugar actually change my risk of losing vision? And that was clearly done in this study, the Diabetes Control and Complications Trial. This study, which was done in large part in conjunction with many centers, but London was a pivotal center, showed that if you took patients who had no retinopathy and treated them aggressively, got their sugars down, and helped them, you could see a 76% reduction in the progression to develop retinopathy. And even if you took those who already had diabetic changes in their retina, but you aggressively tried to control their sugars, meaning don't just say do your best, but actually push them to do better, 54% saw a reduction in the risk. And as you can see from these curves, as time goes by, the benefits grow and grow and grow. And so it's not just a matter of doing it for a short period of time, it's an ongoing need. And that study was done in our type 1 diabetics. This study was done in the type 2s, and it clearly showed the same thing. Controlling your sugars or glucose is important. And it's not just important for the individual, it's important for society. Because in Canada, in 2007, it was projected that approximately $15.8 billion is spent in some form of financial cost because of diabetes and eye care in general. So let's talk a little bit more again about macular degeneration. I already mentioned the dry form, but I want to go a little more into depth. It is the slow decline form. It does not generally provide as severe a vision loss as the wet form, but some people will progress to what we call legal blindness, or only reading the big E on the chart. It's important for all people to realize that this vision loss cannot be reversed. Once damaged, it is permanently damaged. But it's also important to be a little bit optimistic and realize that your peripheral vision, your getting around vision, will always be maintained. There are factors which contribute to developing macular degeneration. I tend to break them into the changeable and the non-changeable ones. The non-changeable ones, well, you can't change your age, you can't change your genetics, you can't change your gender or your race. The alterable or the changeable ones, we can quit smoking and we can provide people with better nutrition. The age one I mentioned earlier, almost 1 in 3 Canadians over the age of 75 will have macular degeneration. Like it or not, is an older person's disease. Smoking has been associated with a 3 to 4 times risk of non-smokers in developing retinopathy, and that is confirmed by the fact that there is a dose response, meaning someone who smokes more has more risk. What we do know is that sun exposure or overuse of your eyes does not increase your risk of macular degeneration. And what I like to say to people sometimes is your eyes were made to use. Please use them, enjoy them. That's what they're for. They also have shown that although cataracts are an age-related associated disease, they have no association in their progression. Having cataract surgery does not speed up the development of macular degeneration. It is associated only in that older people get both diseases. And so with macular degeneration of the dry type, at the present time, all we can do is offer optical aids or magnifiers. Some of these can be very effective in a motivated patient, and some of them are funded under the Assisted Devices Program, or ADP. We know that antioxidants, both vitamins and minerals, which come in a pre-made supplement available at your pharmacy without a prescription, are helpful. I should mention they are only helpful or proven to be helpful in people with macular degeneration. They are not helpful for all eye diseases. And the CNIB provides some wonderful low vision assistance for our patients. And most importantly, I would mention, it is important for all of us to be diligent about monitoring our vision. What we are monitoring for is a change in our central vision, which can only be determined if we close one eye and test the other. And I bet you if I could see the audience today, like any other time I've mentioned this with a live audience, half the audience is closing one eye and testing the other as we speak. Screening for macular degeneration and diabetes most certainly starts in one place, and that's a visit to your eye care professional. Whether that's an optometrist or an ophthalmologist, your vision can be checked, your pressure can be checked, but most importantly, it requires, and I emphasize the word requires, a dilated fundus examination. Most of my practice is macular degeneration or diabetes, and I spend all day, every day looking at the back of people's eyes, and I only do it with your pupil dilated so that it's like looking through a doorway, not trying to look through a keyhole. You cannot do a full examination on an undilated pupil. So for those of you with diabetes or macular degeneration booking your next appointment, it must be done in a dilated fashion. For diabetics, we have similar guidelines brought to us by the Canadian Ophthalmology Society. Those guidelines state that in individuals who are diagnosed with type 1 diabetes after puberty, they should be seen within the first 5 years of diagnosis. If you were diagnosed as a small child before puberty, you should be screened at the time of puberty. And if you're a type 2 diabetic, then you should be screened at the time you're diagnosed. And it's that examination, that dilated fundus examination, that determines how frequently you should be seen. And at a minimum, that should be a once-a-year assessment. And for most people with significant disease, it should be more often than that. Patients who are considering who have become pregnant should also be seen more frequently, and that's because some pregnant patients can have a rapid progression in their diabetic retinopathy during pregnancy. And so the current recommendation is that they should be seen in their first trimester and then seen each trimester thereafter. And despite this, in a developed country like Canada, 38% of people with diabetes have not had an eye examination. And 1 in 3, 32%, don't follow the current guidelines. Part of this is due to a multifactorial reason. One is that patients sometimes don't know how important their diabetic eye examinations are, how threatening it is to their vision, and how effective our treatments are, which we'll get to in a moment. Some patients have access issues. They either live far away from a person who can screen them, or they feel they don't have access because of economic penalties. I would make it clear to everyone that all eye examinations for retina pathology, that means a retina problem, whether it's diabetic retinopathy or macular degeneration, are covered by OHIP. That is not something which you have to pay out of pocket for. You do have to show up, though, to have it. And so I want to move on now to how we treat these. And I want to go back because I really do think that both of these diseases have an interesting and a progressive history on what we do. In the early days, I don't want to say how long ago because it will date me, but in the early days, we applied thermal laser or a hot laser, but that laser could only be applied to about 1% of patients. And what we did was we were looking for that little sweet spot, a very, very small blood vessel growing where you could see it was outside center. And what we did was take our big hammer and drop it right on top of the blood vessel. It destroyed the blood vessel, but unfortunately, it only provided about a 25% reduction in severe vision loss, and almost 50%, flip a coin, of those patients would come back with a recurrence. And so that was a very poor therapy, but we moved on in about 2000. In 2000, we came up with a drug which was called a photodynamic therapy. It was a drug which was infused into your veins. It circulated through your body for 15 minutes, and then we used a non-thermal or a non-hot laser to activate the drug. What that study showed us that we had a much better ability to stabilize patients, and now we were starting to talk about avoiding moderate vision loss. But notice how I'm still talking about vision loss and how the curve continues to decline. It flattens out much more quickly, but it still goes down. And only about 10% of our patients saw an improvement. And so although it was better than the thermal laser, it still wasn't very good. Diabetes was similar. 50% of people who develop proliferative diabetic retinopathy will suffer severe vision loss with 5 years if it's not treated. And what treatment was determined to be was what is called pan-retinal photocoagulation, or PRP. PRP was applied to the periphery and was shown to reduce severe vision loss by 50% and has maintained itself as the mainstay of treatment for over 40 years. And this is what an eye looks like that has received PRP. You can see all the little white and pigmented spots around the edges of the retina, which are little laser burns, which help to slow down and stabilize the retina. So at this point in time, in patients who develop those hemorrhages I mentioned or traction detachments, we only have fewer of them to deal with, and that is almost exclusively done as an outpatient surgery with awake anesthesia, which is much safer for our patients. And diabetic macular edema, or the swelling in the macula, can also be improved with laser. It also resulted in a 50% decrease in moderate vision loss. Again, I emphasize the word loss. And so it really led to a reduction in the cholesterol and a drying out of the retina. But we didn't see that bang, an improvement in our vision until the dawn of a new day. And that really has become, for both diseases, the pharmacologic therapies or anti-VEGF therapies for retina diseases. We have 3 of them currently available: ranibizumab, aflibercept, and bevacizumab. But the important thing is that all 3 work in a similar manner. And essentially what we need to think about is that although angiogenesis, a big word, is really a simple term, our bodies need to grow new blood vessels in order to supply oxygen. So it's a normal process, but it's grown in an abnormal way or gone astray in both wet macular degeneration and diabetic retinopathy. VEGF is the #1 growth factor responsible for VEGF, for angiogenesis, and it results in an increased leakage. And so what we found was when we started using these therapies, for the first time ever, an eye disease hit the cover of Science, and the first drug was available. And when you get 2 eye studies published in the New England Journal of Medicine, it says a lot. And why it said a lot was we were now able to have 90 to 95% of people avoid moderate visual loss. And now we were talking about a 30 to 40% of patients having a significant gain. And finally, we saw that on average, our patients were improving. And so we were not only talking about avoiding loss, but we were talking about gain. And what it did to my clinic was the number of people getting injections grew astronomically and has certainly leveled out, but not diminished. And more importantly, we're seeing a 50 to 70% decrease in the incidence of blindness in many of the developed countries around the world. And so we've had a great impact on vision loss. What we noticed was that the response to treatment was biphasic, meaning had 2 portions to it. In the loading phase, when we did the once-a-month injections, we saw an initial rapid recovery in vision and then a slower response thereafter. And that response eventually did plateau. And so I can't say this is a cure, it's an improvement. And what we also noticed was that because of this initial response, that the current clinical recommendation for all these diseases is that we have a minimum of 3 monthly injections given before we do any changes to the treatment regimen. And it's also important to remember that not everybody is a fast responder. It's the tortoise and the hare. There are some people who have a very slow or limited response in the first 4 months, and about 1 in 6 will show a significant improvement if maintained on therapy and stable by the end of a year. And so we can't give up on people too soon. And in fact, what it's taught many of us physicians is that the goal in the long term is not to avoid injections. What we are aiming to do is to avoid visual loss by preventing things like this large hemorrhage because of trying to stop giving people needles. And what it has also raised is the concept of trying to identify an individualized patient regimen. And how that came about was in one of the studies, rather than just reacting to problems, meaning treating when something got worse or the patient complained, they introduced a proactive component. And what they said was, if we haven't given somebody an injection for the last 12 weeks, even though they're stable, let's re-inject them. Let's prevent further damage. And what that showed was many patients could go 12 weeks and remain stable, but some patients could not. And so it's important that we try to figure out who is who. And that led to a large Canadian study formulated out of here in Toronto called the CAN-TREAT study, in which what we proved was that the treat and extend, meaning the spread people's visions out slowly approach, rather than the monthly approach, resulted in equally good vision outcomes, resulted in a significant reduction by 2 years in the number of injections required. And just think, if we can reduce by 6 injections in 2 years, what's going to happen over 5 or 10 years is much bigger. And if we look as well, over 70% of patients were able to be spread out to 8 or more weeks between injections, and 40% of patients could be spread out to 12 weeks or more. In diabetes, the whole idea is much the same. We treat consistently because of the fact that it has been demonstrated to have a significant and superior vision benefit over laser in our patients with diabetic macular edema or swelling. And that treatment, again, is individualized. We treat monthly until the disease stabilizes. Once there is no change in the swelling and no additional benefit to vision, we stop treatment and we monitor them. And why we're monitoring is we're looking for a recurrence in disease activity. It did show us one other thing, though, and that's that when we were treating those patients with diabetic swelling, we noticed that their overall retinopathy improved. And so it looked like we were making them less diabetic. And so one of the studies done by what's called the Diabetic Retinopathy Clinical Research Network, a large clinical group across Canada and the United States, looked to see whether you could do injections instead of laser, that PRP I mentioned, and maintain vision. And what they showed was that the anti-VEGF therapy was equally beneficial to the laser. It was purported that it would have a slight less reduction in vision loss peripherally and less incidence of surgery. But it has not replaced laser as the primary treatment because of the fact that you are only stable as long as your eye is getting an injection. And so there's a concern when patients are lost to follow-up. And some of the benefits have reduced over the prolonged follow-up. And so, in fact, we still do a lot of laser and we augment it in those with proliferative diabetes with injections as needed. And one of the other big reasons is the cost and treatment burden on our patients is sizably different in those receiving injections. Just talking a little bit about the agents which are currently available. All 3 agents can be provided for you in Ontario. They are all what we call monoclonal antibodies. An antibody targets an abnormal tissue, and it specifically is targeted at VEGF. Unfortunately, I know you'll all grimace at this, but they are all administered by a needle in the eye. There is no other treatment available. No drop, no pill. And they are all initiated on a monthly basis. But what's important you recognize is that all 3 drugs work to rapidly reduce the swelling in both macular degeneration and diabetes, and on average provide an improvement in acuity. Eylea and Lucentis, or ranibizumab and aflibercept, are the two approved therapies and are 100% covered for macular degeneration and diabetic macular edema in all patients on the Ontario Drug Plan. And I do mean 100% covered. Avastin is an off-label drug and so currently not and likely not to be covered in Ontario. It is utilized mainly here on patients under the age of 65 who don't have coverage. And so I just want to talk for the last couple of minutes about the future. We have to think about this because of the growing burden on our clinics, on our patients, on our society. Our population is only getting older. And remember that if 1/3 of patients over the age of 75 have AMD and the population is aging, so is the number of people getting AMD. We're seeing a growing diabetic population, and since retinopathy affects both type 1 and type 2, we're also seeing an increasing incidence of diabetic retinopathy. Fortunately, at the present time, there are at least 5 different agents in or completing phase 3 trials, and that's because they are attempting to target other growth factors or growth factors in addition to VEGF. In dry macular degeneration at the present time, there are no available therapies. I'm happy to say that there are 2 studies currently underway at the Ivey for dry macular degeneration, or specifically the severe form of dry in which people get atrophy or withering of the retina. But again, they are both injections in the eye. And at the present time, there is no stem cell transplantation which is available. It's still a ways off, but it still is a hope for the future. What we need to talk about is a little bit in how our system delays the establishment of care. And that's partly a result of many different factors. And the first one is we need to know who's at risk. And if we're going to determine who's at risk, we need to encourage everyone over the age of 65 or with a family history of macular degeneration to be seen on a yearly basis for a dilated examination by their optometrist. If drusen are seen, you have dry macular degeneration and you need regular and routine follow-up. Our diabetic patients, I already showed you the current screening guidelines. This requires an examination to an optometrist or an ophthalmologist at least on a yearly basis. Once you know if you have these diseases, it's important to monitor your vision, as I mentioned, 1 eye at a time. It's important for our patients with macular degeneration to be started on vitamin supplements. And it's important for our diabetic patients to be aggressively encouraged to control their sugars. They need to know that if you notice a change in your vision, don't delay, don't put it off, don't make excuses. Call your eye care professional and get it checked. Ensure that you're looking out for yourself. What we know is that if you delay care, you do not see the same benefits of treatment. And this slide in the bottom left just shows those people in the studies I showed before that benefited, if they were treated later, sure, it flattened off, but it didn't improve. And so timing is everything. Similarly, we have to not be forgetful of the importance of monitoring and ongoing sustainability of our treatments. Our treatment is expensive. And if it's expensive, what we want to do is gain vision and maintain that effect for the benefit of patients and society. It's important to remember that diabetics never become non-diabetic, at least in the current world. And so there's always an ongoing risk of recurrent edema or progressive diabetic changes. Similarly, macular degeneration patients, whether they receive an injection or not, are never cured. They can be controlled and stabilized, but we don't get younger and the disease is never gone. And really, what nobody who meets me with loss of vision in 1 eye wants to hear, but everybody needs to hear, is that 50% of people who get wet AMD in 1 eye will get it in the other. And so they need to be very diligent and monitor the other eye as well. And monitoring is placing a large burden because of the importance of doing it. But it's also a burden on the patients and caregivers because these patients often can't drive themselves to appointments and certainly wouldn't on a routine visit want to be driving themselves to get a needle in the eye. For some patients, the distance of travel and the cost of making those trips has become an issue. And certainly for those under the age of 65, time away from work and the cost of testing, as well as the cost of treatment, can affect their outcomes. Fortunately, many of our general ophthalmology colleagues have started treating both diabetic patients and macular degeneration patients and are able to limit some of the travel time. And I'm hopeful that the establishment over the past 10 years of the Ontario Telemedicine Network, or OTN, will help with the monitoring as well. At the present time, OTN provides support for some select populations, typically in very far remote sites, but it has the potential for expansion because ophthalmology is unique in the medicine world for the high amount of quality and the highly available digital photographs and OCT machines currently available in most optometry offices, allowing for rapid and concise transfer of information to retina specialists. I can look at a picture of an individual in Owen Sound as quickly as I can look at an image at the back from someone here in London. And so in summary, early retinopathy, whether macular degeneration or diabetic changes, detection is important. It requires a routine dilated examination by either an ophthalmologist or an optometrist or in one of the screening programs. We need to treat the modifiable risk factors. We need to lower our glucose, control our blood pressure, and quit smoking. And most importantly, I would wish on all of you to spread the word that our treatments are effective at improving, maybe not restoring yet, but improving vision and providing salvage to other eyes, and that laser and anti-VEGF injections are effective at preventing and in some instances restoring some of the vision loss which has occurred. And I have hope for the future. There are many new and exciting possibilities, but at the present time, I just want to thank you all for coming and putting up with my issues at the beginning of the talk, and I'd welcome you for any questions. Thank you.
Thank you very much, Dr. Sheidow. Lots of information there to share. I've been monitoring the chat box, and there are several questions that have come in. So some of them have already been answered, actually. They came in halfway through your presentation, and then you immediately touched on the topic. But let's see if we can get some of these questions out for you. Josie has said, I am not a diabetic, but I have part of this condition, possibility for improvement. I think you've touched a little bit on that, is that there are adequate and in fact positive and promising treatments available now that people can take advantage of.
There are. I guess if I'm understanding the question right now, I think that what I would say is if you don't have retinopathy, and if that's what you mean, you're diabetic, but you don't yet have retinopathy, there isn't any specific treatment for you, but it is still very important that although you can rest assured that right now things are stable and good, I think it's really important that you maintain those regular checkups. And that's the most important thing I can encourage, is that ongoing once a year, almost like you have a birthday every year. Make sure you get checked.
Okay, and Scott asks, are retinal issues primarily related to diabetic-related issues?
There's other retina problems. You can have retina problems from blocked veins, blocked arteries, and many other conditions. So it's not just diabetes. But certainly when you look at the back of someone's eye and when you see the type of changes I showed on a few of the slides, and they're present in both eyes, it classically is diabetes. And so I would say that within our clinics, 50% of people, probably closer to 70 or 75% of people have either diabetes or macular degeneration. And so although it's not always, it's primarily those two diseases that we're seeing at this point in time.
Mm-hmm. You've talked a lot about prevention, mitigating the factors that can exacerbate these conditions. So I'll ask a question that Emily has posted, which I think is important for all of us, particularly if we have young people in our household. How bad is looking at the phone for 4 hours a day for my eyes, and will this contribute to vision loss? So what is the impact of elevated screen time on the vision that we're experiencing these days?
But it's actually a good question. And I guess I would start by saying part of me is assuming that because Emily's on this screen, Emily's not a kid. And the reason I say that is it's very different what I'm going to answer, but I'll get off topic in a second. Using a screen, whether it's a computer screen, an iPad, phone, none of those hurt your eyes. Use them as much and as often as you can. In fact, in some of my macular degeneration patients, I tell them, if you can get used to not holding that book in your hand or the paper, get an iPad or a tablet, because the improvement in contrast is actually going to help you read and see better. And so screens don't hurt your eyes. Your eyes can get dry. People with vision loss tend to stare more. The more you stare, the more your eyes dry out. The more your eyes dry out, the more they burn and itch and get sore, but it doesn't hurt them. You don't do any damage. The caveat to that is little kids, young children on screens too much, too long. It has been shown that it increases the development of myopia or nearsightedness. And so we are certainly seeing many more people develop a degree of nearsightedness, which is further through the use, we believe, of increased screen time. Less play outside is also a concern. For some reason, sunlight helps us. Imagine that. But as far as using a screen for adults, we like to get out, but it doesn't hurt us.
Okay, great. Ron has asked if you could provide a little bit more information on the name of the antioxidant that you said was available at the pharmacy that is a great preventative treatment.
Well, I'll give you the two most common ones, but I'm sure that what you can do is if you go into the pharmacy, the name of the study that was shown was called AREDS or AREDS. And the two drugs that you could buy most commonly are called Vitalux or Preservision, and they're both available in most pharmacies. And I suspect that if you go into Rexall or Shoppers or whatever your current pharmacy is, there may be a generic form of them too. Everybody comes in saying, well, I'm taking my lutein. Lutein is part of the antioxidant, is not the whole picture. And so I always encourage my patients to take the full picture. If you're going to take something, take the whole package. And that's why I currently recommend either Vitalux or Preservision. But you can get those bottles and look, and you'll see all the different components that are in it. But it's a component of minerals, vitamins, and lutein.
Interesting. Diane is asking if you could speak a little bit about, and I hope I'm pronouncing this correctly, epiretinal membrane.
An epiretinal membrane is a little bit of, as I put it, scar tissue on the surface of your retina. It tends to affect people's macula. So just like macular degeneration that affects the central portion of your reading, so does epiretinal membrane. And as I commonly say to people, and they think I've stopped talking, the most common reason is just because. No other reason. There are other reasons for it. Sometimes you can get it after a tear in your retina or a retinal detachment. But at the end of the day, what it does is, and this disease used to be called a macular pucker, got to be careful when I say that, the macular pucker causes a distortion in the center by almost like an elastic, bunging up the center vision, but they're not related to diabetes specifically or macular degeneration, but it is just another problem in people's macula.
Okay, thank you.
It can only be fixed with surgery.
Another question is that a vast number of this same population that suffers from AMD also experiences dry eye. Is there any relationship between dry eye and dry AMD, or is it just a coincidence? They're called similar things.
A bad combination of the same word, dry.
Okay.
Lots of people say, you say that they have dry macular degeneration, they think they want to take drops for lubricants. No similarities. Dry eye happens to the surface of the eye. Many of us have less strong or lasting tears as we get older. Dry macular degeneration is in the inside at the back, totally unrelated.
Okay, thank you for that. Final question, and then we'll wrap things up. And this also comes from Emily, and I think it's a great question. How do we currently enable screening for underrepresented or marginalized groups or populations? And what would be your recommendation to enable better screening? to these groups and to the public if catching these conditions early and creating prevention opportunities is so important. Any thoughts on that?
I think, Michelle, if we go back to that slide about delays in care, I think probably the biggest impact in Ontario, and I mean, without at all getting political, I think the biggest impact right now on getting seen is in some people taking the time to get seen. You can't get your eyes assessed unless you make an appointment to get assessed. And I don't mean to point my finger back. I mean to say, as I mentioned, an optometric assessment or an assessment by an ophthalmologist is covered for everybody with an eye disease. Now, yes, if you call up and say, I want to have my glasses checked, I'm 50 years old, I'm not diabetic, I have no other problems, it's not covered. But if you call up and say, I need my diabetes checked, I need my yearly examination, that's covered by OHIP. And so there is no barrier in that sense. The barrier is getting somebody in. And I realize that for some groups that's harder. But through the smattering of optometrists across the province, you really have an optometrist in every small community around. And so that really has helped things immensely. The days of us and them is long gone. I encourage all my patients, see your optometrist. You don't want to meet me. Once you meet me, you're in trouble. So you hope that it's your optometrist who becomes your regular follow-up person. And I encourage that as well. They're closer to home. They get to know you, and all it takes is a phone call. So please just pick up the phone. If there is somebody who's having a difficult time getting in, what they can sometimes, I would argue, do is if they have a group they're affiliated with or assistance is needed in transferring them, then that would probably be where you're looking to enable transfer or some kind of a support worker to get them in. And it may be that if you contact the CCAC or some of those regional groups that provide transport and access for patients, they may be able to help. I'm not sure what's available there, but again, it's a matter of picking up the phone.
Great insight, Dr. Sheidow. Thank you. I think we've got time for about one more question, and I'm going to take Joan's question. And she asks, does having a detaching retina increase the risk of AMD?
Not at all. Macular degeneration is something which you're genetically born with a predisposition to. We don't have a specific gene, but it is a gene that runs in families, and about 50% is related to a couple of different genes. And it comes on with time, meaning we call it a degeneration because it doesn't show up when you're 10 or 15, it happens over time. A retinal detachment is totally different. It's a disease due to a tear in the retina, which is a tractional problem. So people with retinal detachments don't get more macular degeneration, and people with regular macular degeneration don't necessarily get more detachments. The only caveat being when we inject a needle where it doesn't belong in somebody's eye, that needle could cause a tear in the retina. It's very uncommon, maybe 1 in 3 or 4 or 5,000, but that would be the only association and certainly a very small risk.
Dr. Sheidow, thank you so much. You have shared a wealth of information, just the information on the slides alone, but the way you've interpreted and presented it, I think has been so helpful for our audience tonight. And I want to thank you on behalf of the foundation and our audience for sharing your time with us tonight, giving your time to be able to share this information. Thank you so much on behalf
Thanks
of
for having me. I'm always happy to hopefully provide a little more information for everyone's benefit.
We will be calling on you again, let me tell you. I mentioned earlier about the increase in the number of retina cases that we are seeing. In fact, the numbers have risen by 50% in the last decade in terms of the number of people we're seeing at St. Joseph's Ivey Eye. One of the things the foundation is doing is we're trying to create more space for Dr. Sheidow and his colleagues here at Ivey to meet that rising demand and to shorten wait times. And that means that we need to renovate their space and create 3 new retina eye exam rooms and a dedicated patient waiting area to accommodate the increase we're beginning to see. The expansion of the retina care program here at St. Joseph's Ivey Eye Institute is critical to enhancing vision care for our region. And donor support is the only way to fund new equipment and renovate the patient treatment space to extend retina care to even more people across Ontario who need it. And your support will help make that possible. The total cost for this project, it's not cheap. It's just over $560,000. but the value of saving the vision of even one person's eyesight, if we can do that, is priceless. If you would like to learn more about how you can support this critical project, we'd be happy to meet with you to discuss how you can help. Details about the funding priority, including information about how you can donate, are available on our website. We've included a link in the chat if you would like to learn more, and Lisa Giroux of our foundation would be happy to meet with you directly, and we've included her email address in the chat as well. I want to say thank you again to our sponsors, CIBC and the Seabrook Financial Group at CIBC Wood Gundy, for making tonight's presentation possible. And I want to thank all of you, our supporters, for enabling St. Joseph's to stay at the forefront of medical innovation in care for programs such as Ivey. Thank you very much for joining us tonight for our very first virtual Doc Talks. Apologies for the technical expertise. We will do better next time. That concludes our presentation tonight. On to the Stanley Cup. Thank you and good night.